So on this slide, it just shows you how kind of all of these nerve endings are kind of working together at all different levels and layers of the skin. So they're providing information from, deeper levels, more superficial areas, and kind of all working together to give us a full picture of what's happening sensory-wise throughout the skin. So there's also coarse or crude touch. That is read by free nerve endings throughout the skin. It provides information that's perceived as pleasant touch or pressure, as well as sensations of like tickle and itch. This information is carried on the C fibers, so they're really slow, kind of late to the party, so to speak. And tickle and itch are closely related to the sensations of touch and pain. These free nerve endings are carried on those unmyelinated C fibers, and they carry both this crude touch as well as pain. And tickle sensation varies between people. Of course, there's always people who are super ticklish. There are psychological factors, of course, that are related to the interpretation of itch and tickle. Itching, we see itch spots on like skin, on inner eyelids, on mucous membranes of the nose, but we don't see these itch spots. They're absent from mucous membranes and from deep tissues and viscera. And itching can be extremely uncomfortable, and some people will continue to itch even when they're causing pain to themselves. So itch is kind of an interesting sensation, I think. So cutaneous receptors, again, you saw a slide about this earlier in this lecture. They are not proprioceptors. However, their sensory information does contribute to a person's sense of joint position and movement. Again, their contribution is primarily kinesthetic, responding to stretch and increasing pressure on the skin. Ruffini's corpuscles, again, also respond to those static joint angles. So cutaneous innervation, so that's kind of when we talk about peripheral versus dermatomal innervation. So again, dermatomes are an area of skin that's innervated by axons from the cell bodies in one single dorsal root. But then we have in like the plexus, in the brachial plexus and the lumbosacral plexus, several axons come together. Several axons leave the same dorsal root and are regrouped to form different peripheral nerves. So here, up in this picture to the right, you can see all the different axons, 3 different axons leaving the dorsal root C8, coming down to form different nerves. So C8 forms the ulnar nerve. It's forming these other cutaneous nerves of the arm and the forearm. So when there's a lesion to the ulnar nerve above the wrist, if the lesion is, low in the distribution, and let's say there's a fracture or something that happens right above the wrist, you would lose the blue area without sensation. However, if the damage was way up high, and let's say we pulled that, we damaged it way up at C8, if the lesion was up at the dorsal root of C8, we would deprive that entire back region, that posterior medial upper limb, without sensation. So it really matters where along that distribution the damage is. So when we are distinguishing between a peripheral nerve lesion and a spinal nerve root lesion, we need to know what we're dealing with. How much of the area is without sensation? Why is that clinically important, particularly to physical therapists and PTAs? Because of things like modalities, right? We would never want to put a hot pack or a modality on an area of the skin where the person doesn't have intact sensation, because they can't tell us if it's too hot, if it's burning, and we could be causing secondary injury to them. So it's important to look at like dermatomes to help us diagnose a lesion that affects either a single nerve root, or is it we can also use dermatomes to kind of assess the level of spinal cord injury, the sensation level of spinal cord injuries. We want to know, again, what our patient can feel. And again, if the injury, let's say, is really low here, at the wrist, and it just impacted that blue ulnar nerve in this picture, then we're going to approach that differently than we might if the whole back of the arm is lacking sensation. So what else did I want to tell you here? We also want to make sure, how big is the hot pack, right? If we're going to use a hot pack on this arm, how big is the arm, number one? How big is the hot pack? If that hot pack is going to wrap around the entire arm or cover this little old lady's back, we need to do a sensation check on the whole area, right? Not just a small strip. We want to make sure that we are sensation testing the entire area so we know that the whole area is safe. Because if you test it and they're only safe to use the hot pack in a certain area, you might want to grab one of the small cervical hot packs instead of the big giant one that you would typically use for like a back, let's say. Because when people have pain or injury, it doesn't necessarily just fall in one dermatome or one very neat and tidy dorsal root. They may have, damage across several dorsal roots, and so therefore several nerves and several strips of the dermatome are impaired. So baroreceptors. So they detect pressure changes in the walls of blood vessels and in portions of the digestive, the respiratory, and the urinary tracts. They monitor blood pressure, right? They want to know, which is important, right? For cardiovascular health, we want to know what the blood pressure is in major vessels. This plays a major role in regulating cardiac function and adjusting blood flow to vital tissues. Hopefully the body does a good job of monitoring blood pressure and thereby increasing blood flow to certain areas if we need it. Just like if you're running a marathon, you don't necessarily need your gut to be digesting a ton of stuff, but you need those quadriceps and you need your hamstrings to have more blood flow. You need the heart and lung to have more blood flow, but you don't necessarily need, your fingers to be doing a bunch of stuff. So we want the body to be able to adjust its blood flow and send it to where it's needed. These baroreceptors also, of course, monitor the degree of lung expansion and impacts respiratory pace. They also monitor urination and defecation, right? We want to know that our body can measure how full our bladder is and that we can recognize those messages so we can use the bathroom. So again, we talked about proprioceptors a lot. So they monitor joint position, tension in tendons and ligaments, and muscle contractions. There are 3 major groups of proprioceptors, some of which we've already covered, but we're going to cover again: muscle spindles, Golgi tendon organs, and the receptors in joint capsules. So proprioceptors, the muscle spindles, they do not adapt generally. So the muscle spindle is a sensory organ inside the muscle. It consists of muscle fibers, sensory endings, and motor endings. The sensory endings respond to stretch. They monitor changes in skeletal muscle length and velocity, and the velocity of the length change, how quickly that change in muscle length is happening. It also triggers a stretch reflex. So these muscle spindles are again embedded in the skeletal muscle. The specialized muscle fiber inside the spindles are called intrafusal fibers, and of course those outer extrafusal fibers are an ordinary skeletal muscle fiber that lay outside of the spindle.